Good morning, good afternoon, good evening to all my friends across the world. A lot of you would know that India went through a crippling second wave of COVID just a few weeks back. We are in a relative state of calm, while India continues to achieve stability over the existing COVID situation. Mucormycosis, that is often wrongly also called as the black fungus, has emerged as a new challenge to India. Within months from being a rare condition caused by a ubiquitous, largely innocuous fungi, it has been declared into an epidemic. The incidence of mucormycosis has risen more rapidly during the second wave, and reports suggest that by end of May, we had over 15,000 mucormycosis cases in India. Various states have quickly undertaken measures, their task forces, guidelines, arranging separate wards in hospitals for management, as well as procurement of drugs. But why suddenly has the situation happened? It should actually inspire a lot of epidemiological investigation to identify the responsible causes. Some of the risk factors we know are high blood sugar, excessive use of steroids, and then things like potential role of industrial oxygen, impure water in steam inhalers, unclean oxygen cylinders, indiscriminate use of antibiotics, and some topical local Ayurveda medications also some people implicate. None of these have been explored yet, and I think it is important to identify the cause so that we can correct it. A lot of these patients have had hospitalizations, and one wonders whether proper infection control measures need to be instituted in hospitals. And so that's another area of importance of standardizing treatment guidelines and having good hospital infection control measures. Now we know, since this is a platform through which a lot of eye hospitals and ophthalmologists would be participating, a lot of eye hospitals work in isolation. And ophthalmologists may not be the right doctor for the initial treatment, but then a lot of patients come to ophthalmologists because the symptoms start somewhere close to the eye. And yes, very quickly you can lose your sight. So it is important that ophthalmologists learn to recognize the problem, what investigations are required, and what kind of a team is required to manage it. We are thankful to Orbis and Cybersight platform to discuss mucormycosis today. I think all of us as ophthalmologists need to know the disease today. And it's a multidisciplinary approach to treatment of this disease. And today we have a wonderful panel of doctors. We have Dr. A.K. Grover, the chairman of Department of Ophthalmology at Sir Ganga Hospital, a very renowned oculoplasty surgeon, a teacher to many, and is a great prolific surgeon. Dr. Shaloo Bageja, from senior consultant in oculoplasty unit from Sir Ganga Hospital. Dr. Manish Munjal, senior consultant in ENT department at Sir Ganga Hospital, New Delhi. Dr. Shweta Gogia, again a consultant in Department of ENT. Dr. Atul Gogia is a senior consultant in internal medicine and infectious diseases at Sir Ganga Hospital. Dr. Salil Bhargav, consultant radiologist. Dr. Cham Vatal, chairman, Department of Microbiology at Sir Ganga Hospital. We are very thankful to the entire team from Sir Ganga Hospital who have had a lot of experience in managing these patients. I'm sure by now they are exhausted in dealing with these cases across And it's not just patients from Delhi, it's from across North India that they get patients for management. To moderate are my colleagues, Dr. Nishi Gupta. She's the head of ENT at Dr. Shroff's Charity Eye Hospital, and my colleague, Dr. Seema Das, head of Oculoplasty. And they would be introducing the speakers. Over to Dr. Seema and Dr. Nishi.
So Dr. Shaloo Bageja, can we request you to please start your talk?
Good evening, everyone. I'm thankful to Orbis and Dr. A.K. Grover and Dr. Seema and Dr. Nishi for giving me the opportunity to participate in this webinar, which is a hot topic these days. So I'll be basically discussing the clinical manifestation and diagnosis of mucormycosis, the ophthalmic perspective. It is a very known entity to us, and we all know it's a ubiquitous and opportunistic infection caused by fungi of the order Mucorales. Rhizopus was common, and because of the angio invasive nature of the disease and delay in diagnosis, the mortality rate has been reported to as high as 80%. In tropical and subtropical countries like India, the environment is quite favorable for fungal to grow, and the prevalence in India has been reported to about 80 times than the developed countries. And diabetes is considered to be the most important risk factor in India, and India is being called as the diabetes capital of the world. While in Western world, the hematological malignancy and the organ transplantation are the risk factors for mucormycosis. Before the COVID era, we used to see on not more than 2 or 3 cases per year, but we have seen the sudden surge in mucormycosis cases, especially in the COVID wave 2. This has been proposed that this virus itself creates a favorable environment in which helps this opportunistic infection to grow. Like there is a decrease in oxygen, the hypoxic state, the increased glucose level due to the induced hyperglycemia or diabetes, and the acidic environment is created due to the diabetic ketoacidosis and the metabolic acidosis, which decreases the phagocytic activity of the WBC. And the drugs, prolonged mechanical ventilation, and the drugs like corticosteroids and tocilizumab, which are used to save the life of COVID-19, itself affect the immune system of the host. And thus, the COVID-19 virus itself also causes the endothelitis, endothelial damage, thrombosis leading to lymphopenia, and decrease in CD4 and CD8 T cell count. They increase the cytokines, especially the interleukin, and increases the ferritin level. And because of the availability of the free iron in the blood, it's a fertile media for the fungus to grow, and all these factors promote the growth of mucormycosis. So the main hallmark of mucormycosis is angio invasion, leading to thrombosis, infarction, and extensive necrosis in the tissue. We all know the spores are present all around us. We inhale it from the nasal cavity, and immunocompromised patients, they go rapidly to the PNS, and from there they spread to orbit, either directly through lamina or through the infraorbital fissure, or perineural or perivascular spread has also been seen. From orbit through orbital apex, it can get to cavernous sinus, or directly through the cribriform plate, it may go to the basofrontal portion of the cerebrum, or there may be a perineural spread. These patients do have a wide spectrum of presentation, and we should have a high index of suspicion, and we should be well versed with the symptoms. They can have a general symptoms like headache, fever, malaise, facial swelling, numbness, or jaw pain. And among the nasal, they can present with nasal blockage or purulent or blood-stained discharge. So one should peep into the nostril whenever there is a high suspicion of the infection. Among the ocular findings, they can present with the symptoms of bulging of eye, droopy eyelid, blurring of vision, or double vision. So the clinical signs as an ophthalmologist which we see are eyelid edema or periorbital edema, chemosis, proptosis, which is due to the increased inflammation and the disease in the orbit, and the skin discoloration, which is due to the thrombosis and necrosis. Significant necrosis of the tissue will be present as a black shark. Ptosis and ophthalmoplegia occurs when the patient and the disease has extended to the orbital apex or the superior orbital fissure is involved. The patient may present with loss of vision or as a CRO because of the retinal vessel thrombosis or the optic nerve involvement. We should not forget to see the corneal sensation because of the trigeminal nerve involvement, the patient may have non-healing epithelial defect or trophic ulcer. And beyond the eye, we should also examine the nose because of the necrosis, we may see the palatal eschar. So these clinical signs we should always keep in this mind whenever the patient presents to us with sudden ptosis or ptosis or ophthalmoplegia. So whenever there is the clinical suspicion of mucormycosis, we should do endoscopy in the clinic, or we can take the help of our ENT colleagues and send the deep nasal swab. And with the direct microscopy using a wet QH mount, we can have a rapid presumptive diagnosis showing the characteristic aseptate hyphae with a wide branching, and the specimen can also be sent for culture. The molecular method is now evolved and is a useful tool and shows the positivity rate of 70 to 75%, and it gives also identify the strain of the fungi. So whenever the sinus debridement is done, the specimen is sent for histopathology, which in addition to the aseptate hyphae classical, we can also see the angio invasion and the tissue infarction, which is diagnostic of these. Coming to imaging, MRI is the image with contrast is the imaging of choice. CT can be done in those cases in which there is a contraindication for MRI. This imaging not only helps in the localization of the disease, whether it's a sinus limited or it's involved the orbit or it has extended to the cranium. It also helps in know the extent of the disease, so we can plan our management accordingly. This is the image showing the bilateral ethmoid sinus T2 coronal image and showing the maxillary sinus of the left eye involvement with the inferior extracorneal mask seen. This coronal image showing the post contrast showing the non-enhancement of all the muscles, just indicating there is an extensive disease. And in this T180 image, we can see the non-enhancing medial rectal muscle with the orbital disease. This is the diffusion image showing the bilateral involvement with the restriction of the optic nerve and tenting of the globe, suggesting the extensive disease, and we have to prognosticate the patient accordingly. This is some of the examples showing the apical lesion and the extension into the pterygopalatine fossa. So depending on this clinical spectrum, this disease has been characterized as possible, probable, or proven ROCM. Possible is when we have a typical signs and symptoms of the mucormycosis with the typical history and the risk factors. Probable is called when they have a supportive evidence of endoscopy or imaging. And we call it proven when we have confirmed it on direct microscopy or histopathology. So depending on our clinical examination and diagnostic modalities, the disease can be staged. Initially, it was divided into 3 stages by Nityanandam S. et al. But now a more proposed elaborative staging has been proposed by Dr. Honavar, who has clubbed up symptoms and signs, including the diagnostic tool, depending on the stage of involvement, and which help us to triage the patient and customize their care accordingly. There are some of the clinical examples how the patient have presented to us. He's a 47-year-old male who is diabetic, vaccinated, done those. He was home quarantined. He had no history of steroid, but he developed symptoms 4 days after it. The symptom of nasal blockage and intraorbital hyposthesia presented to our ENT colleague. Ocular examination was within normal limit, and the imaging showed the pan-sinusitis, and he was managed accordingly. Another patient of 39-year-old male who was non-diabetic, non-vaccinated. He recovered from COVID, but was readmitted because of the drop in oxygen saturation. He had received 1 cylinder of industrial oxygen and omnacotril for 5 days. He recognized to have a hyperglycemia, but his HbA1c was 10.9, so he was a pre-diabetic. He presented to us the symptom of headache, discharge, facial swelling, double vision, and diminution of vision. On ocular examination, he had left side fullness, mild proptosis, ophthalmoplegia of the grade of -1 to -2, and slight diminution of vision. On imaging, he has a sinusitis along with a localized abscess in the lateral quadrant, which is a well localized abscess abutting the lateral rectus, extending extracorneal and intracorneal compartment. Another patient who was non-diabetic, not vaccinated, and he had received Medrol for 6 days only for persistent fever. And after 2 weeks, he developed symptoms of facial swelling, headache, and jaw pain. So these non-specific symptoms are should be kept in mind whenever we are seeing any patient. However, his ocular examination was within normal limit. He had a sinusitis, that is a retrograde extension into the NRD, and was well managed with the ENT colleague. The fourth case is a 60-year-old female who had comorbidities. She was hospitalized due to low oxygen saturation, discharged, but she developed symptoms of facial swelling. ENT colleague elsewhere has done a sinus debridement with partial maxillectomy, and after 2 weeks, she presented to us with a sudden drooping of eyelid. On ocular examination, she had total ptosis, ophthalmoplegia, and drop in vision, and thus on CT scan, on MRI imaging, she had sinus debridement was done, but she had an apical lesion with the cavernous sinus involvement. And on day 2 of admission, she developed a sudden stroke, and we can see that there is a slow growth in the ICA, narrowing of the ICA, along with the multiple infarcts in the cranium. So we can have wide spectrum of the manifestation presentation, and we should have a high index of suspicion in these cases. The management is, we have 4 critical factors we should keep in mind: early and rapid diagnosis, reversal of the predisposing factor, good metabolic control, initiation of appropriate antifungal therapy, and extensive surgical debridement is the key, especially the sinus debridement, which not only decreases the load, gives us a specimen for histopathology, and improves the drug action on the affected tissue. Thus, a multidisciplinary collaboration is must for managing these cases. Among the antifungal agent, liposomal amphotericin B is the drug of choice as it has lesser side effects and better survival rate. Triazole is also available to us, which can be used as an agent, and also in this present scenario when there is a true shortage of this liposomal amphotericin B. So coming to the oculoplastic perspective, we have 3 things in our armamentarium: transcutaneous retrobulbar amphotericin, orbital debridement, which can be done endoscopically or transconjunctively, depending upon the location of the lesion, and exenteration. So aim is of debridement is to remove the necrotic and the devitalized tissue so that we can reduce the fungus load, and the drug can have a better diffusion into the affected tissue. So transcutaneous amphotericin B has been used in literature earlier for aspergillosis mainly. Now there are few case reports which show that there has a promising results, and some have also used a catheter to irrigate the amphotericin B, and so we can consider the one of the first line option for the treating and salvaging the globe if the disease is not so extensive in the orbit. So this injection amphotericin B is used for the limited or localized disease in the orbit. It can also be used in bilateral disease or the patients who have a poor prognosis where the intracranial extension is severe. It has an off-label use. It should be reconstituted with sterile water to prevent the precipitation of the drug. Dosage I prefer is 1 milligram per ml. The patient who have good vision, restored vision, and for 7 days, and 3.5 milligram per ml I use in who have a gross diminution of vision or no perception of light for 5 days. The injection of site we should choose on the depending upon the imaging where is the localized disease. If it's medial, we can use the supromedial, transcutaneous, or transcarencular approach. Or if we want to approach the intracorneal, or we don't want to reach the apex, we should go through the lateral 1/3 orbital inferior orbit. So we do have the complications. We can see the inflammation is there in after the injection, but it goes in a day or 2. And a compartment syndrome has been reported in the literature, but personally I don't have seen any such episode in my practice. And before injecting the injection, we should also give a xylocaine, depending on how sensitive is the patient. Sometimes the patient can tolerate it. Sometimes we have to give xylocaine before injecting this amphotericin B. This is a patient who presented to us with no perception of light, and we tried to salvage the globe, and we can see the disease in the orbit. And this is the ADC we're showing the hypointense necrotic tissue, but post 3 weeks injection, they have shown a slight resolution of the disease. And so this is a promising modality of treatment, and we should keep in mind if the disease is not so extensive. Orbital debridement, as I already said, if there's a localized necrotic tissue and we know that it's we cannot go with that, and we have to debride all this, and if not possible endoscopically, then we have to go through the transconjunctival route. This is another patient who had the abscess, and then we had debrided it with the transconjunctivally, and postoperatively there is a resolution of swelling and improvement in movements. Coming to the exentration, this is the most destructive surgery, and there are no such guidelines available with us for the exentration, and so basically in the clinical judgment of each surgeon when to exentrate, and the literature has said that the exentration does not affect the patient survival because there are multiple factors involved in the survival of the patient. However, ophthalmoplegia and loss of vision are not the clear indication of exentration. So we have other modalities available to us. So we should, if there is a localized disease, we should go for amphotericin B injection, or we can do the localized debridement if there is necrotic tissue. So the clear indication, what I prefer in my practice for exentration is the extensive disease, the patient presenting with the scinecia. On MRI, there is stenting of globe, the extensive orbital disease, and there is a stretched optic nerve, severe proptosis. So these patients these globes are not salvageable, and we should go ahead with exentration early. This is another patient who presented with no PL, and there are non-enhancing muscles seen on MRI. So these patients should be taken early for exentration. This is the apical involvement and the bulky cavernous sinus. So we should, and there is a restriction in the optic nerve. So this patient was taken up for exentration. However, if we are trying for a transcutaneous info, we should go for sequential MRI, and another 4 days, if we 4 or 5 days at interval, we should go serial MRI. And if we see the progression of the disease, so we should go plan for exentration. However, in burst of the hand and burst of the debridement efforts, we sometimes can't save this patient. The patient had extensive debridement, but still had the intracranial involvement. So I'd like to share my series and my experience at Ganga Hospital. In COVID wave 1, we have only 31 patients, and 29 were diabetic, and we exented 6 patients. But however, in COVID wave 2, we had 131 patients of Rhino-orbital disease, 102 were diabetics, 128 received steroids, and we had to exentrate 25 patients, and bilateral disease was seen in 11 cases. So there's a huge number of patients of mucormycosis, and the mortality was also high, especially in the active COVID patients. So just to summarize, we should have an awareness among the COVID care teams, and they should have a high index of suspicion for Rhino-orbital-cerebral mucormycosis. We should educate the patient on the time of discharge, of the warning symptoms and signs. And the key to good outcome is the early diagnosis, rapid initiation of medical therapy, and extensive and aggressive surgical debridement. Prevention is always better than cure. So judicious and supervised use of mixed steroids, aggressive metabolic control, educating the patients, and to consider if there is any role of prophylactic oral posaconazole in high-risk patients. At the end, I'd like to acknowledge Dr. A.K. Grover, who has been the guiding source all throughout this COVID period and always in my life, Dr. Chand Mathur, who is heading the microbiology department, Dr. Shashi Dhawan, who is a pathologist, Dr. Gogia has always been managing our patients and listening to our queries, Dr. Salil Bhargav, Day in and day out, he's teaching us about the MRI and the progression and disease pattern. We have worked as a team with our ENT surgeons, and at the last, not my resident, who have worked day in and day out in my tough situations. Thank you.
Thank you, Dr. Shaloo, for that comprehensive talk. And we had a couple of questions from the participants. I'll just take one of them, which is related to the retrobulbar amphoby injection. So do you use xylocaine before giving the injection routinely, or it's a direct injection? And if you use xylocaine, how much amount do you use?
Yeah, I use xylocaine about 0.5 ml normally before giving the injection, and wait for 2-3 minutes, and then I inject the amphotericin, because patients are already so apprehensive. So I have not tested them without xylocaine, but some people say they do use without xylocaine, and patients are comfortable, but I have not tried them without xylocaine. I give them xylocaine before injecting the amphotericin.
And in your experience, what has been the success rate with this injection? How effective do you find the injection?
In our 40 cases of this injection, 6 cases we had to exenterate. The rest were milder forms, so we were able to manage. But in those also 5 cases, it was mild to moderate, but they have progressed faster, so we had to exenterate them. And the key is the sinus debridement along with the medial extracorneal debridement, because they do the endoscopic debridement. So most of the necrotic tissue they remove. So the load is reduced, and thus the action of the injection is also more. But when the load, there is a progression in the sequential MRI, then we continue with the injection, but we do keep the close watch in these patients, and we have to do every 4th or 5th day MRI scanning to see the progression.
That was an excellent talk, and I would like to invite the next speaker, Dr. Manish Munjal. Dr. Manish Munjal is a senior surgeon in Otolaryngology department of Ganga Hospital, and he'll be talking on mucormycosis diagnosis and management, the ENT perspective.
So at the outset, the Dr. Shaloo, I mean, I just don't know, these days it's more like a family than being colleagues. We are seeing each other day in and out, and not to talk about Dr. Shweta, Dr. Varun, all the IE and ENT residents. So it's that kind of situation which we are facing. As she has said, 131 cases treated so far, and even today, as of today, we have more than 60 cases admitted in the hospital. We are facing new problems every day, and through this forum also hope to have some light on that. Being a very common disease, there is bound to be and common management, there are bound to be some slides which will be the same. But I'll run through one of them. And as we have mentioned, we talk about fungal sinusitis, because the basis of this fungal infection is the sinus and the nose mucosa. And out of them, but most of them are benign. And around 50 of them are the ones which cause systemic or CNS infections. And based on all these things, they can be categorized into invasive as well as non-invasive sinusitis. So we very well see the incidence of non-invasive sinusitis all throughout the years in the form of allergies, in the form of mycotomas. But whenever the fungal hyphae, which where the spores, they break into the mucosa, submucosa, bone or blood vessels, they become invasive. And based on that, there is a classification where allergic and fungal balls, they in fact are mentioned under the category of allergies. And along with that, the invasive ones, which are the most dangerous, and in that also the acute invasive fungal sinusitis infection, which you are broadly going to talk about, that's mucormycosis, is the most dangerous. But of course, there are some chronic variations like chronic invasive fungal sinusitis and chronic granulomatous also, which we see much during our clinical practice otherwise. But why is acute invasive fungal sinusitis most lethal? Because the mortality rates are described in the range of 50 to 80%. Thankfully, it is rare in immunocompetent patients, and basically it has two type of clinical populations in India that are involved, and because one of them are the diabetics, which are heavily numbered in India, and the other ones are the immunocompromised ones with severe neutropenia, as Dr. Shaloo had mentioned. That may include chemotherapy patients, bone marrow transplant, organ transplants, AIDS, and now not to mention about the post-COVID convalescence patients. So this is the new category in this. The species, especially the Mucormycosis species, we are talking about the Phycomyces class of the order Mucorales, also known as rhizomer mucus. And these are the ones which are the most commonly involved with this kind of problem. These species have an active ketone reductase system that enables to thrive in a glucose-rich medium, where the acid pH is also low. And basically, it has been seen that the hyperglycemia leads to impaired neutrophil chemotaxis, and individuals with impaired glutathione pathway are the most commonly affected. So the rhizopus species also favors an iron-rich environment and are frequently associated in patients receiving this iron chelation therapy. The next thing is about the talking about the symptoms of such patients. We do have, whenever there's an occurrence, patients with the, as Dr. Shaloo had mentioned, the occurrence of headache, nausea, fever, lethargy. Sometimes you will not find too much of symptoms other than this. But then, of course, one would like to see symptoms of nose, like purulent discharge, stuffiness, a little bit of thick discharge coming out, a little bit of bleeding. And one symptom that we have found much infrequent and very specific symptoms is this intraorbital hyposthesia. Of course, there are orbital symptoms that are beautifully described by Dr. Shaloo, where there is periorbital or retroorbital pain, sometimes leading to ophthalmoplegia symptoms like diplopia, blurred vision. And of course, we don't want symptoms like these, where there is convalescence, this convulsion issues, dizziness, unsteady. That means we have a brain involvement. When we have a look at these patients, you will also find sometimes a nasal and palatal findings, where you find this gray or erythematous appearance in the initial part, which can later on progress to black necrotic masses. That's black eschars. And from there, we all know that the name black fungus has found its place. Of course, one has to do a very thorough clinical examination through neurology, where we have to check whether there are any palsies, not to even talk about cranial nerve 1, we always look at that, but other nerve palsies like second, third, fourth, fifth, sixth, and seventh nerve also not infrequently is seen. Smell sensation is usually a confusing thing, as I said, because in COVID patients, that thing sometimes is invariably gone, and it's wrong to ask them whether they can smell or this thing, and it doesn't lead to anything. But of course, ocular findings of cellulitis, proptosis, fixed pupil or dilated pupil, and if the lid is not rising, third nerve involvement, also sometimes nystagmus and blindness that is seen commonly with these things. We don't want to see a patient in this situation where there's already a swelling coming in and both the eyes are involved, and therefore early detection is the key, and we must recognize the symptoms before it is too late. So what are the keystones to management of mucormycosis? The first step is not commonly these days where they have panic video calls and all those things, but we must insist that the patient must come in for an ENT or an ophthalmological examination. The second step would probably be a radiological imaging if required, and if it is present, not on the first meeting. There is a role of, as Dr. Shaloo also said, a very good role of nose endoscopy and subsequent biopsy or culture. There is, of course, a role of surgery. I'll place the role of surgery a little bit above and over the medical management, but they go synergistically hand in hand, of course. Even for radiology, as we mentioned, even small sinister um, um, uh, examination, like just a little bit of thickening in this sinus, but if you don't miss it, the T1 image showing a little bit of fat suppression and all is to be taken seriously and has to be correlated with the symptoms that the patient is giving. Of course, some people do believe in a CT finding, and there are many patients who do not like to get an MRI done initially because of various issues, where good CT examinations also may reveal soft tissue thickening, hypotenuting mucosa with aggravation, rapidly aggressive bone destruction of sinus walls, and also sometimes an isolated, never before happening unilateral involvement of ethmoids and sphenoids also should give us a little bit of insight into the possibility of disease. If one does an MRI, which is, I think, a contrast MRI is the investigation of choice. T1 fat suppressed images and T2 images are ideal, and we are learning them day by day, where you do get a beautiful idea of the thickening around the cavernous sinuses and the optic nerves and everything, and even a staging is very well possible. So there are some things I'll not discuss them because Dr. Shaloo has already discussed, but this is one side where there is a invasion around in the cavernous sinus along with the petrous and the intracavernous part of ICA getting engulfed around with the disease. Of course, there's suppression of image in the sphenoid, which shows active disease in that part. And there could be small these satellite infarcts also in the parietal, in the temporal lobes, which could be indicative of possibly thrombosis in the internal carotid artery happening on that side. So as I said, it is important that an MRI, whenever there is a definitively or a serial requirement for examination, an MRI is one of the best investigations of choice. And out of that, we have found that in early diseases, obliteration of periantral fat that's around the sinuses is a good subtle sign of extension and needs a more urgent attention than just a sinus involvement. The sample collection is one of the most sensitive and important part of a treatment of mucormycosis, and it should be really prompt. We must use peripheral tissue samples which encompass disease as well as healthy areas. Middle turbinate samples are great for biopsies, but one must take samples from these areas also sometimes where there is not possible to do punch biopsies. Like this example, I think it just happened in the morning today. We sent it for a pus culture KOH smear and it came out positive. So these subtle areas of discharge from the antrum are very important. We cannot miss, of course, these black eschars and with fungal mycelia, as can be seen in this slide so easily. And such cases are very easy to diagnose. But even then, once we have done the sample, it is important to use too much of saline, and these samples must be sent wet to the microbiologist without any crushing or freezing, and they must be put for the best results within 15 to 20 minutes without any preservatives. So it's always a challenge, and only then you will get these beautiful, courtesy Dr. Wattle's department, these slides where they have seen these beautiful acute branching aseptate hyphae along with these thickened ones, and a beautiful growth coming in later on. So what do we do when we have an acute fungal sinusitis or a mucormycosis situation? The first thing which we have learned, and especially in the era of diminishing availability of the vital drug amphotericin, is aggressive surgical debridement. That is one of the most important things which we have learned in this wave, and it has helped save many lives. And of course, whenever we can, we must start the antifungal therapy, if possible, reversal of the underlying cause of immunosuppression. And that's why we must, Dr. Atul Gogia will probably talk about it, how to schedule the dosage of steroids and stopping them. Recovery thus from neutropenia is one of the most predicted form of survivals. And of course, the death rate is largely defined by the intracranial spread. It cannot be treated alone, as we have found out very well. We always had ophthalmologists along with us, but we have realized that it is much, much important to have an infectious disease physicians around us all the time, because we are severely immunosuppressed individual. Sometimes because of the nephrotoxic effects of drugs, we need nephrologists. We have to frequently send patients to intensive care units, and intensivists, neurologists, and among us, both of us, we are required in these cases. We must prognosticate early to all patients, because they have a fulminantly fatal clinical pattern, and patients with without or with sinus involvement also in higher stages may have mortality rates up to 50 to 80%. And of course, with intracranial invasion, mortality can exceed that also. Important from the surgical point of view, as a surgeon, we must realize that they are basically the most common 3 points of entry of this infection into the body, into the paranasal system and to the skull. One is the most common, which is the transnasal route. The other one, which is opening up and we are seeing increased number, is the transoral route, where it comes through the foramina of the dental foramina. And the third one is the transorbital. So from the nasal cavity, the mucus, the fungus is seen invading the lateral wall mucosa, then from the turbinates to the maxillary sinus, to the pterygomaxillary space and deep neck spaces. This is the inferior lateral spread. It may reach the intracranium or the middle cranial fossa through the foramen ovale placed laterally in the skull base. From the superior, which is also sometimes very dangerous, from the ethmoids, it can reach the anterior skull base and the frontal lobe, and that is the superior spread. From the ethmoids, it can even go superior lateral, and through the orbit apex, it can go through the cavernous sinus, and that's the superior lateral spread. And the posterior spread through the foramen rotundum, sphenoid, clivus, it can go to the middle. So various ways it can go into the brain. From the dental foramina, we can see the necrosis of the hard palate, maxilla, and the premaxillary space. And of course, the least common, which is a direct orbital spread, can be through the conjunctival presence of disease. We have seen a few cases of this where there's a pan-global involvement, and then subsequently the orbital apex and cavernous sinus gets involved. But the focus of our infection is this little space behind the maxillary sinus, and this is called the pterygopalatine fossa. The disease then takes a route either superior laterally, superior, posterior, inferior, and this crucial reservoir of disease, the exploration must be included in all infections. So first of all, the team will decide the exclusion criteria for the management. If the patient is very poor GC, there's significant intracranial involvement, severely compromised, all the other factors, one should take a decision whether one can treat this person. But once you take the decision, the first thing you must really evaluate is whether you can do a widespread endoscopic debridement in this case. We have to stage these cases early for that. And later on, things like orbital exentration and multiple stages of surgeries and also check endoscopies form a part of treatment. Although we have other classifications, we will share it later on. Our mucormycosis study group has staged them into 5 stages. We are trying to build a consensus on these stages, where there's subunit one side of the nose as category 1, then more than one subunit where there's no lamina papracia involvement and no skull base involvement. Then of course, there is a stage 3 where there's further lamina papracia but not frank eye involvement. And then there's involvement of the medial compartment or lateral spread into the pterygopalatine space. Then stage 5 is of course significant extranasal spread that includes the brain and all. So it helps in prognosticating the disease. One small clip of for those who want to see how the fungus looks like. This poor man who already has an orbital involvement, one can go in and see these disease processes, a necrotic mixed up middle terminate, and going from there, we enter laterally into the space, the sinus called the maxillary sinus. We use these beautiful debrider machines, which we use in normal fest surgeries also, and try to remove as much as the disease part as possible. Along with that, you can see that so much devascularization of the sinus mucosa, but that when you are removing it, these purplish patches of devasculated mucosa filled with pus pockets of the fungus, they come out in the thing, and slowly you try to attain the areas of clearance. Going forward, sometimes you have to enter the maxillary sinus directly, and this is called a Denker's approach, where we approach the inside of the cheek and go directly into the sinuses to break the pre-maxillary space and into the area which is the infratemporal fossa on the posterior wall. Furthermore, you have situation like this. This is the pterygomaxillary space which we are talking about. It's behind a very tough bone, and later on we open this space. After opening, these are the lateral pterygoid muscles, and once you put in your instruments and try to take out the fat, one can see a lot of pus trickling out. So this is all endoscopic. Then, of course, once you are sure that the maxillary artery and all the severe vital structures, they are preserved, then you enter the space, and with a debrider, you remove all the necrotic material, which may include, unfortunately, the maxillary artery lumps. And here you can see the fifth nerve, V2 segment, that's the maxillary nerve reaching up to the foramen rotundum. Sometimes you have to do painful decisions like removing the median nerve and have to reach up to the foramina. One little thing that I do sometimes is the decompression of the orbit. This is the lamina pepraceae, where there was significant orbital disease in the area of the medial compartment of the eye. And once you remove the lamina and you open up the periosteum, you see the pus trickling out. And this person, we could save the eye, one of the eyes that Dr. Shaloo showed. And with this, we can really get some time to treat such patients. Of course, I'll not talk too much about, but the definitive therapy is usage of amphotericin B. I think Dr. Gogia will be talking a lot about that. We as surgeons do use this topical application through an atomizer spray of this amphotericin B in saline solution. It has been recommended at many centers. There are no clinical trials talking about its efficacy. But in the end, after a few weeks, this is the kind of mucosa you need to be looking at after surgery. And one little small endoscopy that you do once in a while, that gives you a joy that this person is not going to die of the disease. As said, results pre-COVID, we used to have a survival rate of only 50%. And that was probably because the systemic manifestations of the mucormycosis came in because of very serious diseases like renal transplants, bone marrow transplants, and things that you would see in a tertiary care center. In those cases, we used to still do surgeries, more than one surgery per patient, but we still used to have slightly higher mortality rate. But after the coming of the wave 1 of mucormycosis, which we saw in December 2020, as Dr. Shaloo said, we saw about 30-40 cases. We were very disturbed with the amount of incidents, but we could save up to 60-70% of those cases, and that primarily probably was because of the immunoreversal of the patient as soon as the steroids and everything was done, and we had only 5 mortalities on that post-COVID group out of the 30-40 cases. This was the mucor COVID time data at that time. So in the end, I would say the key points in COVID times is that a multidisciplinary team is even more important, because the immunosuppression is of a different kind. People are coming out of COVID with all those complications, and there is a steroidopathy, there is a multi-organ stress, there is also possibility of sepsis in these cases. Secondly, because of amphotericin being less and less in amount, a wide surgical debridement is more required than even earlier times. Whenever you get high dose amphotericin or lipid complexes, one must do. But thankfully, post-COVID survivors are still better than earlier times. We are doing many projects on this, and hopefully we'll have more data on this coming in. I thank to everybody who has been mentioned in Dr. Shaloo's slide, and also our young doctors all over the, not only Gangaram, but all over the place, who have come forward and helped to bring this COVID menace to the minimum, and hopefully for the disease itself. Thank you so much.
Thank you, Dr. Manish. That was really a very informative talk. There are many questions in the chat box. We can take just one that says,
Sure.
What are the reports and incidents of mucormycosis outside of India?
All right. So this comes out of a very interesting webinar which I had with Dr. Chakravarti from PGI. He's a very renowned microbiologist and authority on mucormycosis, and we were always discussing that why do we have so many cases and the West has so many little? Because we had extensive talks, and our hospital is attached academically to Harvard School also, and they reported in the whole wave of mucormycosis, Boston Medical School could only report one case of mucormycosis. So largely said 80 to 85% of mucormycosis population, rhino-cerebral mucormycosis, is in Indian subcontinent. And one of the things which our microbiologists who would like to comment on that is probably the presence of more fungal spores in the environment of the Indian subcontinent, which might be one of the reasons. But other than that, clinically speaking, there is no doubt about the fact that invariant use of steroids where it was not required in even mild to moderate this COVID infections, giving very high dose of steroids, which was required for treatment, but without any monitoring of sugar in the houses, and also in some medical treatment centers, along with the fact that the steroids were tapered in a very, very long duration. That could be one of those factors. Then we all know that this fungus loves iron and rich environments, and also probably heavy metals like zinc may have helped in the progression. These are the causes where we can say definitely for sure that there's some amalgamation of truth in higher incidence of mucormycosis in India. That I would definitely say, but these studies have to be done at a larger level, in a more detailed level.
So I think that answers the question. To add a little more to it, we can say that the mucor was always there in India. Yes. But the cases reported in the literature are that we saw only one case in 1,000. And right now we are seeing 5 cases per 1,000.
Yes,
so if we talk about 1 case per 1,000, so that means that incidence also was 80% more than the other countries. Absolutely. So could be because of the causes that you have explained. I think that answers the question. And now, Dr. Seema, we can invite the next speaker.
Thank you, Dr. Manish. Thank you, Dr. Nishi. So we will move on to the talk by Dr. Atul Gogia now, and he's a senior consultant in the Internal Medicine and Infectious Disease Department at Gangaram Hospital. And we know with 2 infections together, which has a lot of systemic implication, the role of an infectious disease physician is so important. So look forward to listening to your perspective, Dr. Gogia.
Thank you, Dr. Seema. Thank you, Dr. Grover and the Orbis team for having me on board today. Actually, everything has been so well covered. There's hardly anything for me to tell. Actually, Dr. Manish only recently has told me that he's learned how to manage all the comorbidities on his own. So probably now our role goes down, because with the current pandemic and the surge in all the cases of mucormycosis in this COVID era, we all have been working as a team, and we have seen that everybody is now seeing the other side of the story. So my ophthalm and ENT colleagues have already described all these symptoms, and the focus generally of my colleagues is on these areas. It is the orbital, periorbital, nasal. So this already has been discussed. So we have to go beyond this as an internist or infection control. So we have seen so many weird pictures. So I wanted to make it a little prettier, that this is the bird eye view of the whole story I would like to give you. So this is how we would like. So we, as an internal medicine doctors, our job is more, like a detective. So we've discussed that it's mucor, we've discussed that it's rhizopus species, all these species are there which lead to this. So how does these patients get to predisposed to this disease? We have had enough discussion about the risk of COVID-19 per se triggering use of steroids, comorbidities like transplant, malignancies. But from time immemorial and from whatever literature we have seen and whatever cases of mucor we have seen in pre-COVID times, also the major risk factor, which I believe today also remains uncontrolled diabetes mellitus. So if you see all the literature, more than 80% of the cases would be having uncontrolled diabetes. And the newer trend which we have seen in recent times is use of voriconazole therapy and the azoles, which are used as a knee-jerk reaction by most of us clinicians. And that also has led to a surge in mucor. It is just not steroids, it's the other therapies also which are being used, which are precipitating predisposing conditions for mucor to invade, because it's already lying there, it is ubiquitous, and it is just the invasion which is required, and that would happen once there is immune suppressed status. So prolonged ICU stay is happening in these patients. So all these are adding up to an increased risk of mucormycosis, which was a disease, as was rightly highlighted by Dr. Shaloo and Dr. Manish, that we have been seeing cases earlier also, but the surge is because the number of cases which are affected right now is large. The COVID-19 patients are large. A lot of patients are getting undiagnosed or getting diabetes. So that is what it is happening. So we all have already discussed about rhino-orbital, rhino-cerebral mucormycosis, but as internists, we have to keep our mind and ears open, because we have to see for other sites of mucor, because that is something which is sinister. So we've had pulmonary mucor, we've had GI mucor, we've had recent GI mucor presenting with perforations, we have disseminated mucor. So those things also have to be kept in mind while we are managing such cases. Although rhino-orbital and rhino-orbital-cerebral remains the most common variety, but we have to keep our eyes and ears open to the rest of the systemic or other organ involvements which we may see in such patients. So as the diagnostic modalities have already been discussed, so the most important part is a microbiological examination. No infectious disease can be controlled by an apt microbiological sampling, and by the apt department we have of microbiology headed by Dr. Atul, where we are immediately informed of these kind of things. So it is very, very important to set in the sample, whether it is a nasal sample or from the eye or from the bronchoalveolar lavage. And as soon as you hear that there are non-septate hyphae, you should start immediately thinking of mucormycosis or zygomycosis, as it was known as. So, and culture should be attempted to be sent. Culture should always be sent for speciating and later on also for us to be able to get good data from the microbiology lab for susceptibility to various antifungals, because in current scenario, we are already running short of the antifungal therapy. So this is just a pictorial representation. If you see one on the left, the A is how a typical hyphal mucor would look like, and the C is something which is like, see the aspergillus is how it looks like. The D1 is again a mucor. They are broad, aseptate. So that is how. So this is from where I've adapted some of the guidelines, which is the global guidelines for the diagnosis and management of mucor. It was a European group study where there are a lot of Indians also involved in this study. As we've already discussed that we are having the maximum number of mucor cases across the globe. And if you see, as currently we are talking about COVID-19, but other conditions like neutropenia, diabetes, trauma, or per se no other symptoms have also been predisposing factors for developing mucor. And radiological investigation is the modality wherever there is. So whenever such a patient is presenting with high clinical suspicion should be there, facial pain, sinusitis, proptosis, imaging is to be done, MR preferably, or a CT depending on. CT would obviously probably tell you the bone destruction better, and sampling, as we have discussed, a biopsy, histopathology along with microbiology would help us. Going on to the treatment, as we discussed, the most important aspect is multi-systemic approach. It is just not only surgical debridement, because surgical debridement along with medical management both have to go hand in hand. So as soon as you are able to find out that there is a strong suspicion of mucor, it should be treated like an emergency. Rapid action needs to be taken. The purpose of surgical debridement should be threefold: disease control, histopathology, and microbiological diagnosis, plus immediate treatment initiation. All of us are aware the liposomal amphotericin B is the drug of choice. So we should not wait for it to be started. As soon as we are able to lay hands on the drug, it should be started. Full dose needs to be started on the very first day. Slow escalation is not to be done, that we will give a low dose today and see how the patient reacts and increase the dose gradually. That is not to be done. So 5 milligram per kilogram on day 1 is the treatment. If there is CNS involvement, 10 milligram per kilogram is the dose which is to be given. If there is pre-existing renal compromise, then we have to involve our renal colleagues, some patients, or there are other drugs which can be given, although they are second in line drugs like isvaconazole or posaconazole, which are both available in IV formulation as well as oral formulation. The question always arises, how long do you treat these patients? How much amphotericin you give these patients? So the response has to be a clinical response as well as a imaging response. So if you are able to establish a stable disease or a partial response, then that is the time you can think of switching over from intravenous therapy to oral therapy by way of using posaconazole or isvaconazole. Posaconazole is available in 2 oral preparations. One is a suspension and other are 100 milligram tablets. So the thing is that if you are using suspension, the thing is that you have to ensure that it is taken along with food, especially a fatty meal, for adequate absorption, whereas in the tablet formulation, this problem is less. So it is 300 milligram twice a day for first days, because I see people giving various doses in various formulations. So it is 300 milligram twice a day for day 1 and 300 milligram once a day from second day onwards. That is posaconazole. If you go to esfaconazole, again the dosage is 200 milligram 3 times a day for first 2 days, and then 200 milligram per day from day 3 onwards. So that is the schedule which you should follow. If you are using an oral suspension of posaconazole, it is 200 milligrams 4 times a day. So surgical debridement along with this therapy. So this just sums up what you have to do. Clinical findings, underlying features consistent, do an imaging, taper off, reversal of underlying disease, which Dr. Manish highlighted. So most important is to get the steroids to as minimum or off. There is a lot of controversy as to how much steroid to give, how long to give. So all patients who are moderate to severely ill only are to be given steroids. Mild patients, non-hypoxic patients, steroid should completely be avoided. Blood sugar level control is very, very important. We have to ensure blood sugar levels target of less than 180 milligrams per deciliter, which is, I am telling you, very, very difficult. We have been managing COVID patients for over a year now, and the kind of steroid and the diabetes which is there, it is very difficult to manage this hyperglycemia. And most of the patients sometimes would require insulin infusions, but we have to do it. That is very important. Immunosuppression therapy, if any other immunosuppressive drugs, a lot of patients who are already renal transplant patient, getting COVID, high risk for mucor, getting steroids, they're already on other immunosuppressive drugs. So we have to discuss this with our colleagues and get the immunosuppression to bare minimum, which we can do. Surgical consultation, obviously we've already that. Without extensive resection debridement, we cannot achieve a stable or a remission in the disease. And as I discussed in the previous slides, that amphotericin for initial 3 weeks, see the response and then shift over to oral drugs. And when we are talking about salvage therapy, when we've done all this, still the patient is not improving, we can raise the dose to 10 milligram, add on the other drugs along with that. A combination therapy may be used. There are various other therapies which do not have any standardization guidelines of use, like hyperbaric oxygen, iron chelators, GCSF, interferon, and soda bicarb for reducing acidosis. But these are all anecdotal and have been used in small cases, but not very, very substantial. So just a brief overview of these drugs I will give before I wind up, because we are using these drugs left, right, and center. So we should have just a view of what these drugs. So this is just a word about amphotericin B. So we have only read in the books about various formulations. With the current shortage, I'm sure all my colleagues and myself are seeing all the variety of amphotericin coming. Someday patient is getting one variant and someday the other. So we have the deoxycholate or the conventional amphotericin B, we have the liposomal, we have the lipid complex, and we have the colloidal dispersion. So we have got all varieties are there. Their dosage is a little different in the sense that the deoxycholate, the dose is 1 to 1.5 milligram per kilogram, whereas the liposomal and the lipid complex, the dose as we've discussed is around 5 milligram per kg, and for the colloid disposal it is 4 milligram per kg. So these are the various formulations which are available, and this is the various structures. I'm not going to details of these because of paucity of time. This is just a mnemonic for all those, and we are aware of the side effects of amphotericin B. So it's like anemia, muscle spasms, phlebitis, headache, hypotension, hypokalemia, thrombocytopenia, emesis, encephalopathy, respiratory stridor, increased temperature, that is fever, chills, immediate hypersensitivity, nephrotoxicity, bronchospasm. So you can all, and there are other rare side effects. As we have been using this drug extensively and in high numbers, so we have seen rare side effects like conduction defects, cardiac defects. We have seen long-term side effects of hearing loss as well. So that is also for my ENT colleagues. We have to be aware that when we are giving high doses of amphotericin B, we've seen patients losing their hearing. Just a word about posaconazole. There is a lot of confusion. I was telling you earlier only that various formulations are there. So as the preparation is 100 milligram, we should get that 300 milligram twice a day for 1 day, that is 2 doses, and then 300 milligram once a day. So it is not 100 milligram 3 times a day or something, 300 milligram once or twice a day, depending on the day. And if you're giving the oral, enhanced bioavailability is there. IV, obviously, whenever there is a pricing concern. What are the common side effects which we see with posaconazole? Well, we can have neutropenia, we can have anorexia, electrolyte disbalances. Hypokalemia can also be there with posaconazole. There are neurological side effects of headache, paresthesias, abdominal discomfort, diarrhea, flatulence, raised liver enzymes. So we have to monitor the liver enzymes, and a lot of these patients already have raised liver enzymes. So we have to monitor and very closely follow this. Rash and pruritus can be there, and fatigue and fever are also some of the other side effects. This slide especially put in is because a lot of these patients are already on different drugs. So we have to be aware of drug interactions. So you will be seeing transplant patients. So posaconazole has a lot of interaction with all these sirolimus, cyclosporin, tacrolimus, and steroids. If the patient's on ART, protease inhibitors, there are interactions. Cardiac patients, statins patients are getting calcium channel blockers, so digoxin, then chemotherapeutic agents. So we have to be aware of all these things whenever we are using these drugs, because no harm is what is taught to us as clinicians. We do no harm is the primary aim. So we have to tailor module. So this is again isaconazole. We've already discussed the dosage, 200 milligram Q8 hourly, and for 2 days, and then once a day. Side effects, important side effects being cardiac also, hypokalemia, and drug interaction. Again, it is very important to know the drug interactions. There are a whole lot of other drug interactions which are happening. So there is an increase or decrease in the levels of the isaconazole with these drugs. So just to sum up, we have to have a team approach. Do's and don'ts, we have already discussed. Control hypoglycemia. We have to monitor blood glucose level post-COVID discharge, and in diabetics, steroids have to be used judiciously. Use of clear sterile water for humidifiers during oxygen therapy. Use of antibiotics and antifungals judiciously. This is most important, which we have to do. And what we don't have to do is don't miss warning signs and symptoms. Don't consider all cases of blocked nose as cases of bacterial sinusitis, especially when the setting is there, and do not hesitate in seeking aggressive investigation as appropriate for detecting fungal etiology, and don't lose crucial time to initiate treatment for mucormycosis. Thank you. Stay safe and strong. Thank you so much.
Thank you very much, Dr. Atul, for summarizing. I know this is a never-ending topic, but in the interest of time, we had to kind of wind it up. So, Dr. Nishi, would you like to open the panel discussion?
I would like to welcome you all on this interesting topic. We've heard a lot of interesting talks, and there are some of the panelists who have not put up their views. So I would like to ask these questions first to Dr. Salil. I think as a radiologist, you are the most important person in this era who actually guides us what to remove and what to preserve. So we all know that MRI is the investigation of choice, but there was a question from the audience also, and it would be good to touch that part also for you. If the MRI is not available, what is the significance of CT? Would you order CT, and what are the things that we can see on the CT scan?
Yeah. Coming to the question, I would definitely order a CT without any hesitation in a patient who either cannot tolerate being in the MR gantry for that long, or who is too unstable and is moving too much. And on a CT scan itself, there are about 7 signs that are very specific for invasive fungal disease in the paranasal sinuses. And a score of 2 or 3 or more of those signs is enough to be more than 95% specific. The difference between MR and CT comes only in the ability of MR to demonstrate which areas have a larger burden of disease. So in CT, we might see everything as increased attenuation. In MR, I am able to pick up more clearly that this specific area has a lot of fungal load and has necrotic tissue and is probably in need of surgical debridement because your drug won't reach there. On CT, that call might be a little difficult, but saying that this is invasive fungal is not difficult. So in short, I would order a CT without any hesitation.
Okay. I think that answers the question. This was one of the audience who had asked that. And I would also like to add that there is an article by Middlebrook et al. That gives you 7 specific signs that we can look at the CT scan. Like you could have orbital invasion without any bony breach, and there are other little signs of septal ulceration, etc. So those who do not have access to MRI can go for CT scan, but yes, we all agree. Yeah.
I would like to add a small point that as ENT surgeons, generally when you order a CT, the scan center or the hospital is used to printing films in bone window. But when you're suspecting mucor, a soft tissue window is really important. Just as you described, finding tissue on either side of the sinus, whether it's the maxillary sinus and you see tissue in and in front of the sinus in the premaxillary space, or behind in the retroantral or pterygopalatine fossa. So just seeing that soft tissue is enough on both sides of the bone without significant bony destruction, or even some rarefaction is enough to say this is probably invasive.
Question, how reliably we can predict necrosis on MRI? I know we are relying a lot on MRI to tell us which are the vital and which are the devitalized area. So how predictable is that?
So necrosis in mucor is of 2 types. One is necrosis because an area of soft tissue has been replaced by fungus. That can occur in the premaxillary area, the retroantral or pterygopalatine fossa, or the medial orbit. The other kind of necrosis that happens is necrosis distal to the site of an arterial involvement. So you can have involvement of the palatine artery and an infarct of the palate without actual mucor disease in the palate. So both of these types of disease will show no enhancement on the post-contrast study. The T2 weighted images and the diffusion weighted images tend to show T2 hypointensity in areas where there is fungus, and not if it is just an area of infarct, which has varied other signals. But the characteristic signal of fungal tissue is replacing a particular area is very characteristic. So using T2 diffusion and contrast, you can pretty much characterize an area as being reactive edema, inflammation, infection with inflammation, infection with obvious devitalized tissue and necrosis, and infarct, as in bone infarcts.
So I would now like to move to Dr. Atul for a couple of queries, very common queries related to the microbiology. So we know that some of the guidelines do ask for a positive microbiology report even for initiation of the treatment in some situation, especially these days when the disease is such a large scale and some of the medicine sometimes are in kind of scarcity. So what is the sensitivity of a KOH? How reliable we can just find it out on KOH, and what is the sensitivity of doing a blind nasal swab in case an endoscopy is not possible immediately to start the treatment?
Well, this is basically an unscientific question because it is guided by the guidelines from the government that we won't give you the medicine. So now, having said that you see the limitations of the microscopies have to be there. Whatever you may say, it depends on the eyes behind the microscope that is actually looking at the slide and trying to give you the diagnosis. If you look at the literature, the KOH has a sensitivity of around 73 to 80%, but unfortunately the specificity is relatively poor. It drops down to 35 to 45%. Whereas if you look at the cultures, is the other way around. But unfortunately, cultures are sensitivity is around 46%. So this is the KOH, and it depends. Certainly, its sensitivity can go as high as 80 to 85%, depending on the experience of the viewer who is trying to process and look at it. It also depends on the type of sample that you are giving, how good the sample is. You refer to a swab, but the swabs are actually not the good samples, excepting what Manish said, that some pus samples, they took a chance and we found hyphae in that. But you would not know the invasion as it is. Because many times, unless you take a biopsy or the tissue at the margins, you will not be able to get the diagnosis as in a confirmed manner at all. You may get on a swab just an aspergillus, which is maybe misleading because these are very common commensals as well. But when you do the biopsy, you can see actually either a mixed infection or you discover mucor there. So these are the things when Manish said that you do histopathology oblique culture, it has not to be the oblique. It has to be done both, because for sure the invasion histopathology will tell you, whereas we will tell you in our KOH and culture, primarily in the KOH, which is the quickest way of knowing. Once the sample is there, in another 30 minutes, we can reach back to the clinician and tell him that you are faced with a mucormycosis, because it's so classical. Any microbiologist who has seen it once will never forget it all his life. So these have a very characteristic appearance, and it's very difficult to get a wrong diagnosis by and large. The guy has to go totally off, or the sample is not good to get into the negative results. So more often than not, you will be able to procure the drug. But always in fungal infections, the most important thing is the clinical diagnosis. It's sad that due to shortage of drugs that you are guided, you have to show a report before you get a drug. That's actually not the science. Basically, in fungal infections, I will repeat, primarily it is a clinical diagnosis which works as the first. And all these studies have taken gold standard as the clinical suspicion and the clinical diagnosis. They have taken that as the gold standard.
Dr. Grover, can I ask you the next question on how do you decide on exenteration and what is the role of conservative management?
Thank you, Dr. Nisha. I think, first of all, let me thank Orbis and thank Shroff Eye Center, you, Dr. Seema and Dr. Umang for the opportunity to have this team, multidisciplinary team from Gangaram, present all the aspects of the disease. I think what they have highlighted is how a multidisciplinary team is critical to the management of this condition, and it is the team that has to do the management of this condition. The diagnosis critically depends on the support of the microbiologist, the pathologist, and the radiologist. So I think that is the first take-home message from this. You asked about the management based on the clinical and the radiological features, which helps us decide between conservative treatment and going in for a surgical exenteration. One important thing to realize is that medical management is critical, along with nasal debridement or sinus debridement, which has to be complete, as well as the debridement of all the areas, including the pterygopalatine fossa, including the premaxillary area, wherever the spread may be. That deburdening is the first critical essential part of the therapy, combined with appropriate full dose medical therapy, as was stressed by Dr. Atul Gogia. Then comes the question of orbital management. In the orbit, there are several factors that weigh in. When we looked at the picture in wave 1 and looked at the picture in wave 2, we have seen some changes which have been very important in decision making. What we do realize is that there are a lot of younger patients that have got involved in this pandemic. They have got involved in the active stage of the disease, and bilaterality has been almost 10%. And we've had exenteration in 24 cases, which is almost 20% of our 131 cases. This is because the disease severity and the initial presentation was quite severe in the beginning of this wave. There has been some change in the picture as the wave has progressed. The precise points which will help you make the diagnosis are whether the disease is localized or whether it is a diffuse disease, and what radiologically you see as dead areas, areas with fungus, as Salil has so beautifully pointed out, or areas which are still enhancing on contrast. If you have inflammation, you can very well manage medically combined with debridement. And wherever there is a localized disease, you can use well-directed, appropriately positioned retrobulbar therapy to augment that. But whenever the disease burden is severe, involving the entire orbit, you have proptosis, you have positive pressure on the orbit, then you need to think of exenteration to debulk, to reduce the burden of the organisms. However, there are cases who have an associated active COVID disease and have problems in being given any kind of anesthesia. They can't be taken up for debridement and will be only taken up for retrobulbar injections. Similarly, those with very bad prognosis like bilateral disease, extensive intracranial extension, we will not be able to take up for exenteration, and we may do with just the retrobulbar injections to decrease the burden of disease.
Thank you, sir. That was very informative. And Dr. Seema, if you can hear me, I think we all agree that if the optic orbital apex is involved and if the disease is going towards cavernous sinus, as there was one case shown by Dr. Shaloo also, who later on went on to have those patchy involvement of the brain. I think those are probably the definite indications of orbital exenteration. What do you say, Dr. Seema?
So Dr. Grover, just a quick question. Have you seen patients with a purely eye involvement without any sinus or nasal involvement?
No, we haven't. The portal is through the sinuses. There have been a couple of reports which I have seen from some of the presentations from all over the country. We have a huge pool from all over the country now, where people have presented without any prior known disease of COVID, and they had just the eye presentation with some apical involvement because of a sphenoid sinus pathology, and then they were picked up to be COVID positive. But those are very much the exception. In our series of 131 cases, we do not have any without the sinus involvement. And in fact, earliest patients presenting to us are sent to the ENT surgeon to confirm the diagnosis, to look at the possible pathology on endoscopy. And that, in fact, is the best way of diagnosing early cases.
Thank you, sir. So, Dr. Atul, couple of questions in the message box regarding the systemic management part, specifically on the use of steroid. So, what is basically safe or rational steroid, say in a non-hyperglycemic patient who has COVID and has fever for more than 7 days? So, what should be the protocol of steroid use? What is safe?
Yeah, there's a lot of debate as to this. If you see the international or now the Indian latest Government of India guidelines, if you see the use of steroid is clearly for people who are moderate to severely ill, that is people who are hypoxic. So if you see, the use of steroid came in from the recovery trial, which was done in the UK, and that was the only drug apart from low molecular weight oxygen and other treatment which have shown definite benefit. So the dosage which is recommended is 6 milligrams of dexamethasone once a day is what is recommended dosage in most of in the guidelines. That is the recommendation. But people are using varied amount of dosage, and obviously if the fever is persisting beyond 7 days in non-hypoxic patients also, there was this guideline to use these steroids. And the most of the guidelines, if you say, they would say that steroids should be stopped within 7 to 10 days. But sometimes in the clinical setting, it becomes very, very difficult, but that's what the guidelines say.
Dr. Shweta, you have been doing a lot of cases, I know, and depending on the extent of debridement, in your experience, as Dr. Seema said, the threshold of orbital exentration is going down now, because we've been doing a lot of endoscopic orbital debridement and other things. So what is your experience of those cases done endoscopically versus the orbital exentration? How do you see them? What is your follow-up? I would specifically like to ask you, those cases who have undergone endoscopic orbital decompression or debridement, we have a lot of questions, all of us, because none of us has actually seen the post-op patients. We've received some of the photographs. Some patients have done very well and some have really worsened. So what is your experience with your cases?
Ma'am, we did a lot of learning from the experience, learning from the MRI teams that this area needs to be addressed, the medial part of the orbit especially, because that is one of the earliest areas to be involved. And if we are doing a endoscopic orbital decompression and if we are able to decompress up to the orbital apex, normally we get very good results, and it alleviates the patient's need for going into an orbital exentration. So taking up a patient who has involvement of the nose, and we see that there is involvement of the pterygopalatine fossa. So it becomes very important. I think it is now we have learned from the cases that we've done that it is important to address these areas, especially the pterygopalatine fossa, which is a large reservoir for the disease. Though the bone might look healthy once we've opened the maxillary sinus, sometimes we just see a healthy bone there. But once we remove that bone and see the contents in the pterygopalatine fossa, then we are actually astonished to see that there is a lot of disease which is residing in that area. And if that disease remains there, obviously it will serve as a conduit to go into various other regions, because that is just like a highway, and it's going to serve go into many other regions of the head and neck. So this region and the region of the medial compartment of the eye, this is, I think, very, very important to address while we are taking up the patients for a surgical debridement. If we address both these regions in the first surgery, in the first initial surgery, once we are seeing the patients, I think we can avoid many repeated surgeries also. Because once we take these patients up for repeat MRI scans or radiological scans, then we very often find, disease still lingering in those areas. So it is very important to address these areas. And in the post-operative period also, all these patients who we did orbital decompression or we did the medial compartment in these patients, they responded really, really well to the treatment, and we could discharge them fast. The requirement for amphotericin was quite less. And I think we could avoid the more disfiguring surgeries in these patients. So it is of vital importance to address the medial compartment of the eye. And also we can, if we are suspecting something which could be residing in the inferior compartment, that can be addressed at the same time. If we, we take up the floor of the orbit through the maxilla approach, we do a Denkers, and then we can address the entire medial wall, the inferior wall, and even to some extent the lateral wall of the orbit, which goes a long way in the recovery of the patient.
Thank you, Dr. Shweta. I think we would like to now wind up, and I would like to say thank you to all the panelists and all the speakers. In these challenging times of pandemic, discussions like these are very critical in understanding the new challenges that come along, like that of mucormycosis. We thank Dr. Umang Mathur, Executive Director at Dr. Shroff's Charity Eye Hospital, for spearheading this entire initiative. Our sincere thanks to the entire team of Sir Gangaram Hospital, led by Dr. Ashok Kumar Grover, Chairman, Department of Ophthalmology at Gangaram Hospital, and a Padma Shri awardee. The discussions led by you, sir, they have been very enriching and would guide all the participants to understand and manage the epidemic of mucormycosis. We thank all the esteemed speakers, Dr. Shaloo Bageja, Dr. Manish Munjal, and Dr. Atul Gogia, for taking out time from your busy schedules and sharing clinical manifestations, diagnosis, and management from an ophthalmologist, ENT, as well as an internist perspective on mucormycosis. We are really grateful to all the panelists, Dr. Shweta Gogia, Dr. Salil Bhargav, and Dr. Chand Bhattal, for such thought-provoking discussion on management of the disease. And a big thanks to Dr. Seema and Dr. Nishi for being such an excellent moderators and facilitating all discussions. And finally, thanks to all the wonderful participants for your presence and valuable questions. Thank you, everyone. Have a good day ahead. Stay safe and stay healthy.